Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar organized by Amogs website and publications committee. It's my privilege to introduce the MOC of today's webinar, Dr. Swati ma'am. Ma'am is the consultant obstetrician and gynecologist at St. Anne's Hospital, Aurangabad, and also ex-registrar at Holy Family Hospital, Delhi. I welcome you, ma'am, and I hand over the session to you.
Thank you so much. Moving toward our program, today I would like to invite Dr. Sujit Konkar, sir, to introduce all, to give a brief details about today's webinar. And Dr. Sujit Konkar, sir, he is a MD OBGY GMC Aurangabad. He has done his basic USG training, Dr. Bimal Sahani Sonoscan Center. He is FMF certified in 11 to 13 week scan. He is a past secretary of Society of Fetal Medicine, vice president of Fetal Medicine Foundation Marathwada chapter, past chairperson of Fetal Medicine Committee. He is a chairperson and website and publication committee, director of Shri Hospital Foxy recognized USG Training Center, and he is interested in advanced fetal ultrasound. Welcome, sir.
Thank you, Dr. Swati, for nice introduction. Good evening, respected seniors, dear friends and colleagues. It gives me immense pleasure to welcome you all for this webinar. I invite and welcome our chief guest today, respected Dr. Sunita Tanurkar ma'am. We need your blessings, ma'am, for this webinar. I invite and welcome our guest of honor today, Dr. Venkatraman sir and Dr. Radha Lakshmi ma'am. We are eagerly waiting for your words of guidance. I invite and welcome our President Amogs, Dr. Kiran sir, who is a constant source of inspiration and guidance. I invite and welcome respected Pardeshi sir, who has been a constant source of guidance to not only for Amoxians but also all Foxy people. I welcome our chairpersons today, Dr. Sridevi ma'am, Dr. Venkateshwara Rao sir, and Dr. Aruna Kumari ma'am, who are interested in your special remarks and comments after the talk. I invite and welcome most important persons today, our speakers and their topics. I am going to talk on early pregnancy, ultrasonography features of early pregnancy, normal and abnormal, special male pregnancies. Respected Dr. TLN Praveen sir will be talking on structural evaluation in first trimester, and Dr. Tulika Joshi is going to talk on importance of third trimester scan. I welcome all delegates who have logged in. So I request Dr. Swati to take over for further proceedings. Thank you.
Thank you, sir. Thank you, sir. A brief introduction. Now I would like to invite and introduce our chief guest, Dr. Sunita Tanurkar, madam. She is President-elect Foxy.
Sunita Tanurkar. You don't need my introduction. Let's not waste academic time. Let me talk to all of you. First of all, thank you, Sujit. Thank you for giving me an opportunity to be with you all. Thank you for allowing me to share with Dr. Pardeshi sir, Dr. Lakshmi madam, Dr. Rao sir, Dr. Praveen sir. Thank you so much for everyone. Sujit, you are a very sincere and hardworking. I know you are working. You have worked. I was watching you in Dr. Rajendra Singh Pardeshi's Amogs presidency, the way you were doing work, and now you want to enter in a Foxy. You're going for imaging committee, and I wish you all the best. I think the way Dr. Rajendra Singh Pardeshi is standing strong with you as a pillar of strength is really appreciable. And I wish you all the best, Sujit, because your hard work will always help Foxy. Foxy also needs people like you, dear. So thank you for giving me an opportunity, and I wish you all the best for this webinar and your future endeavors. Thank you.
Thank you, ma'am. Thank you.
Thank you, ma'am. Thank you for your kind words. Moving toward, I would like to invite today's guest of honor, Dr. Venkatraman sir. He has done his MBBS Kurnool Medical College, MD from Mangalore. His special training, he is trained in laparoscopic surgeries, 25 years services in Kurnool Medical College as an assistant, associate, and now head of department, retired at. Presently, he is working as a professor OBGY Vishwa Bharati Medical College, Kurnool. He has done more than 50,000 DPL surgeries, advanced laparoscopic surgeries. He is a IMA Vice President, member of Safe Motherhood Committee, Dhira Award, Best Doctor Award, President of Kurnool OBGY Society, Andhra Pradesh State Government DPL trainer. Welcome, sir.
Good evening, everybody, seniors and my colleagues. I am very delighted to be the participate in this webinar. Thank you very much. Thank you, one and all. We'll wish all the success of this webinar. Thank you.
Thank you, sir. I would like to invite our second guest of honor, Dr. Radha Lakshmi ma'am. Dr. Radha Lakshmi ma'am, she is the secretary of Kurnool Foxy, professor of OBGY. In the Santhiram Medical College, Nandyal. She holds a key position in several professional organizations, including General Secretary of Foxy, OBGY Society of Kurnool and Nandyal District, Zonal CME Coordinator of Zone 6. She has completed her study in the Kurnool Medical College with outstanding performance and had received Best Doctor Award in Kurnool 2017. She has contributed to medical literature with several publications and conducted various conferences and CMEs. Welcome, ma'am.
Thank you, Sujit, for including me in this webinar. Thank you, Rajendra sir and Praveen sir and other members of the webinar. So wish you all the best, Sujit. I want to see you as the chairperson of the Imaging Science Committee 2025. Wish you all the best.
Thank you, ma'am. Now I would like to invite our guests, Dr. Rajendra Singh Pardesi, our own. She has 28 paper presented with 20 national and 7 international.
It's okay, Swati. Thank you. Good afternoon, everybody. Respected Chief Guest, Dr. Sunita Tanwakar, ma'am, Dr. T.L.N. Praveen, sir, Guest of Honors, Dr. Venkat Ramanna, Dr. Radha Lakshmi, and our Amogs President, Dr. Kiran Kurtakoti. First, I wish to congratulate Dr. Sujit Konkar for organizing such an academic webinar with stalwarts like Dr. T.L.N. Praveen, sir, Dr. Tullika Joshi, and chairpersons Dr. Sri Devi, Dr. Aruna Kumari, Dr. Venkateswara, and with the active and ever smiling MOC Dr. Swati Parihar. I wish every success to Dr. Sujit Konkar for his future endeavor in Foxy for the chairperson of Imaging Science Committee Foxy in these forthcoming elections. Wishing every success to this webinar. Thank you so much for inviting me. I don't want to be in between you and scientific content. Thank you so much.
Thank you, sir. You have always been a pillar to our society. Moving toward our scientific program, inviting today's chairperson for the first webinar, Dr. Sri Devi, ma'am. Dr. Sri Devi, ma'am, she is Associate Professor and Department of OBGY GMC Ongle, undergraduate at Kurnool Medical College, PG at SVMP Tirupati. She's a gold medalist, got Best Doctor Award 2 times in the District Collector, trained in Harvard T2T, did Diploma in Diabetic Management and member of MEU. Welcome, ma'am. I would like you to invite our first speaker, Dr. Sujit Konkar, sir.
Good evening, doctor. Thank you for your kind introduction. I'm very happy to be in this webinar. I heartily congratulate sir, Dr. Sujit sir. Dr. Sujit sir, he did his MD at GMC Aurangabad and basic ultrasound training in Dr. Bhimal Sahani and Sono Scan Center. FMF certified for 11 to 13 weeks scan, PE, screen Doppler, ultrasound and fetal abnormalities. And he is a chairperson, website and publications committee, AMOGS. Director, Sri Hospital, Foxy Recognized Ultrasound Training Center, interested in advanced fetal ultrasound. We welcome you, sir, for this session, and we are very happy to be with you, sir.
Thank you for a nice introduction. Now I would like to share my screen. Good evening, respected seniors, dear friends and colleagues. At the outset, I would like to thank Dr. Kiran Kurtakuri sir and Dr. Bipin Pandit sir for giving me this opportunity for my this webinar. So my topic is very basic topic: early pregnancy, ultrasonography of normal and failed pregnancies. This is basic because all obstetricians are having sonography machine, and at least what they can do or they are doing is scanning in for early pregnancy and follicular study. So the details of early pregnancy, normal features and features of failed pregnancy is very, very important in day-to-day practice. So what are the goals of early first trimester scan?
Sorry to interrupt, sir. Your slides are not visible.
Now is it visible?
No, sir.
Unshare and then again share it. Stop the sharing and then share it again so that you'll get it. Yeah.
Yes, now we can see your slides.
Yeah, you can see it. Okay.
Thank you, sir.
Thank you. So what are the goals of early first trimester scan? So to confirm an intrauterine pregnancy, and obviously to look for the features of extrauterine pregnancy, to date a pregnancy, because the dating of pregnancy done at this stage is much more accurate than dating done in latter part of gestation, to confirm number and viability of the feti, to assess chorionicity and amnionicity in multiple pregnancies, to assess early fetal morphology and deviations from normal, because many abnormalities can be diagnosed at 9 to 10 weeks of gestation, and looking for uterine anomalies and maternal pelvic pathology. This is very important in early pregnancy because once the uterus grows out of pelvis after 11-12 weeks, then these things are very difficult to define. Now, regarding safety, many are very much worried about safety of the ultrasound in pregnancy. Ultrasound is very safe. Transvaginal 2D and color flow mapping are safe, but fetal spectral Doppler is questionable. So whenever you need to measure fetal heart rate in early pregnancy, always go for M mode and not for Doppler. Remember, we still use this LRI principle as low as reasonably achievable. Some terms should be clarified here. We call it as an embryo till 10 weeks. After 10 weeks, it is called as fetus. Abortion refers to patient's choice of terminating pregnancy, and natural events are referred to as miscarriages. Now, these terms, blighted ovum, missed abortion, inevitable abortion, these are old terms. We do not, no longer we use it. It should not be used. This is a very nice article from ISHRI regarding the terminology of pregnancy loss prior to viability. I am not going to read out all this, but we'll see some important terms. We call it as early miscarriage when there is intrauterine pregnancy loss of less than 10 weeks of ultrasonography. And when it is more than 10 weeks, it is called as fetal miscarriage. Unembryonic miscarriage is called when the intrauterine pregnancy loss is with gestation sac without yolk sac and embryo. And when yolk sac is there without embryo, it is called as yolk sac miscarriage. The commonest term used, embryonic miscarriage, is when intrauterine pregnancy loss with an embryo without cardiac activity on ultrasonography. Another important thing to highlight here is transvaginal sonography is the imaging modality of choice in evaluation of early pregnancy because it provides highest resolution images. But remember, golden rule, always first examination should be by transabdominal probe to have an overview of the pelvis. Sonologist must be aware of normal and abnormal appearances of early pregnancy. Misunderstanding of normal anatomy and developmental milestones may lead to incorrect diagnosis and incorrect treatment. And another important message, TVS does not cause miscarriage. There is very great misconception among patients and many clinicians about TVS, but remember that TVS does not cause miscarriage. Usually the fertilization occurs in the ampullary region of the fallopian tube, and after 5 to 6 days, the blastocysts gets implanted into the residua, giving positive pregnancy test. And the journey starts from beautiful rounded structures to variety of C-shaped structures like this till the embryo is 8 weeks. These are the schematic representation of embryos, 6 weeks, 7 weeks, 8 weeks, 9 weeks, 10 weeks, and 12 weeks. But we'll start from a beginning. Order of appearance in early pregnancy is very, very important. And first thing to appear is small gestation sac. It is called as intradecidual sign, which is seen at 4.5 weeks. It is seen as small 2 millimeter size sac, which is eccentric to the central echogenic line, and it has got thin echogenic rim, which is called as choriodecidual reaction. So this is a good image of sagittal section of uterus. So we expect the normal gestation sac in the upper part of uterus and on either side of the midline, not in the center, never in the center. Next to come is double decidual sac sign, which is seen at 5 weeks. Decidua is the endometrium of first trimester. It is seen as a rounded or oval fluid collection surrounded by two echogenic rings. Outer ring is decidua and inner ring is chorion. But there are some pitfalls. Commonly, double decidual sac sign is confused with pseudosac, which is seen in around 25% of ectopic pregnancies. But there are differences. Pseudosac is elongated and centrally placed. It has got acute angles. It is teardrop shaped, and it is avascular. Small decidual cysts can be confused as small gestational sacs, but these decidual cysts are well remarcated cysts in endometrium, usually not abutting endometrial canal. They don't have any echogenic rim. Remember that these two signs can be absent in 35% of pregnancies. Next to come is yolk sac. It is the first structure identified within gestational sac. It is seen at 5 to 5.5 weeks, just 3 to 5 days prior to embryo. It confirms intrauterine pregnancy. That means once you visualize yolk sac into the gestational sac, the positive predictive value of intrauterine pregnancy is 100%. It is spherical in shape. It has got sonolution center and it is having echogenic periphery. It is occasionally seen as two parallel lines at the corner of gestational sac. Embryo is attached to this yolk sac via wetland duct and from which it gets all nutrients. The normal diameter of yolk sac is 2 to 6 millimeter. Anything more than 7 millimeter is called as abnormally large yolk sac, which may be associated with abnormal fetal outcome. And in multiple pregnancies, number of yolk sacs usually equals to number of amnions. This is how it looks on 3D. So this is in multiple pregnancies. There are two yolk sacs, means two amnions, diamniotic with clear-cut lambda sign, diamniotic dichorionic pregnancy. Here are two amnions with only single T sign, suggestive of diamniotic monochorionic pregnancy. And in third image, you can see two embryos, but only one yolk sac. That means this is monoamniotic monochorionic pregnancy. Important message here: yolk sac size is not a parameter of for just assessing the gestational age. You have to just measure it and forget. Next to come is fetal pole and cardiac pulsations seen at 6 to 6.5 weeks. Embryo appears like a little dot on yolk sac, which is also called as diamond ring sign. Cardiac activity may be seen as a flickering in this area. So this is how it looks on 3D. Then next to come is important, very important structure is amnion. It is seen at close to 7 weeks. It is a thin membrane surrounding embryo, which is thinner than yolk sac. Up to 10 weeks, mean diameter of amnion is 10% larger than that of CRL. The embryo is in amniotic cavity and the yolk sac is in the chorionic cavity, that is extraembryonic coelom. So at 7 to 9 weeks, the amnion is expanding. The yolk sac is free floating in chorionic cavity. As continued growth and development progress, the embryo visibly changes from a dot to a grain of rice to a more kidney bean shaped structure. So embryonic morphology is better seen on 3D. This is a 6 weeks fetus. 7 weeks fetus is L-shaped. That means there is a right angle between head and the body. The umbilical cord is considerably thicker and limb bursa are just, you can see the limb bursa. 8 weeks embryo is open C-shaped. The umbilical cord is thinner and the proximal part of limb bursa are clearly seen. Then 9 weeks embryo, the umbilical cord again got thinner. The distal part of extremities are nicely seen and you can see the nice curvature of head and abdomen. And this 10 weeks embryo, you can see along with other features, you can see the physiological gut herniation, and this is the 12 weeks embryo. So order of appearance again is the embryo is renamed as fetus after 10 weeks. By the end of first trimester, organogenesis is complete and there is fusion of amnion and chorion at 14 to 16 weeks. So order of appearance is very, very important. This order should not be altered. It may result in failed pregnancy. So first to come is interdecidual sac sign, then double decidual sac sign, then yolk sac, then fetal pole, then cardiac pulsations, then amnion. Coming to measurements in early pregnancy, there are 3 important measurements: mean sac diameter, crown lump length, and fetal heart rate. Mean sac diameter is the mean of 3 orthogonal planes, that means 2 longitudinal planes and 1 transverse plane. In a normal healthy growing pregnancy, the rate of growth of gestational sac is 1 millimeter per day. Another important message in this context: do not use mean sac diameter for dating of pregnancy. Never use mean sac diameter for dating of pregnancy. You just measure the mean sac diameter, write it on the paper and forget. Now next is crown lump length, which is very, very important biometry in early pregnancy. Many things depend on correct crown lump length. Dating depends on correct crown lump length. Many decisions depends on correct dating, like various investigations and diagnosis of your growth disorders depends on correct CRL. This is the ESOC criteria for measurement of correct crown lump length. The fetus should be midline sagittal. The orientation should be horizontal. It should not be oblique or vertical. The magnification should be such that the whole screen is occupied by the fetus. The position should be neutral. It should not be hyperflexed or hyperextended. There should be some fluid between chin and chest. Endpoint should be clearly defined. That means your measurements are correct. And between 6 to 9 weeks, ISWAG also states that when here embryo is hyperflexed, you can use we use neck rump length instead of crown rump length. Third is fetal heart rate. As already mentioned, whenever you need to measure fetal heart rate in early pregnancy, always use M mode and not power Doppler. Heart rate is visible after CRL 2 to 4 millimeter, and as shown in this graph, in the early part of gestation, fetal heart rate is somewhat on lower side. At 8 weeks, it is 145 to 170 beats per minute, and after 9 weeks, it settles down to 137 to 140 beats per minute. Coming to some terms, viable in context to obstetrics. Obstetric scan viability means which results in live born baby after 24 weeks. But strangely, when we talk of early pregnancy scan, only two criteria is sufficient to label it as viable scan. First one, demonstration of intrauterine pregnancy. The second one is demonstration of fetal cardiac activity. These two things are sufficient to term as viable pregnancy. Non-viable means which cannot result in live born baby, and intrauterine pregnancy of uncertain viability comes under gray zone. Coming to miscarriage, it is the spontaneous loss of pregnancy before it would be able to survive independently. Fundamental principle of scanning in first trimester and labeling as a miscarriage is first do no harm. That means misdiagnosis of failed pregnancy is not acceptable because it can lead to inadvertent termination of a normal healthy growing pregnancy. So strict cutoffs are available for diagnosis and strict time intervals are available for repeat scans if initial scan is inconclusive. So this is a very nice article, Diagnostic Criteria for Non-Viable Pregnancy Early in First Trimester by Peter Dowlett Group. It has laid ultrasonography signs of early pregnancy failure. Some are definite signs which tell you that the 100% surely this pregnancy is non-viable. Some are worrisome signs. You need to pay attention, but do not rely on that. And some are less predictive signs, hard to apply. Definite signs are CRL based, mean sac diameter based, and time based criteria. Coming to CRL based criteria. So remember, when crown rump length is 7 millimeter or more and you don't get fetal cardiac activity in that fetal pole, you can straightway label it as a failed pregnancy. No need for follow-up in these cases. Previous criteria was 5 millimeter, but it has been updated. So the positive predictive value for this failure with this CRL is 100%. When CRL is less than 7 millimeter, it is mostly demise, but here we need to call the patient for follow-up. Again, important thing here is you must be sure that you are imaging embryo and nothing else. Two things can be confused with the fetal pole. One is lobular wall of gestational sac and another is chorionic bump. A newcomer may take this as fetal pole, put M Doppler, put M mode, and obviously there is no cardiac activity. It can be falsely labeled as failed pregnancy. This should be avoided. Next one is mean sac diameter based criteria. So when the mean sac diameter is more than equal to 25 millimeter and you don't get fetal pole with cardiac activity into that, you can straightly label it as a failed pregnancy. Previous criteria was 20 millimeter, but now it has been updated. Positive predictive value for failed pregnancy with this 25 millimeter cutoff is 100%. Mean sac diameter between 16 to 24 is suspicious but not diagnostic. There is again new evidence. When the patient is having very regular cycles and even more than 70 days after LMP, if the mean sac diameter is more than 18 millimeter without embryo and crown rump length is more than 3 millimeter without any fetal cardiac activity, you can straightway label it as miscarriage. Remember that all this discussion is applied when you are using transvaginal scan. Because of some reasons you are not using transvaginal scan, you are using transabdominal scan, it is always better to call the patient after 14 days for reassessment. Now coming to time-based criteria. CRL-based criteria and mean sac-based criteria, they are single scan. On a single sitting, we are giving the diagnosis of failed pregnancy to the patient. But there are a number of pregnancies which do not reach the milestones of CRL 7 millimeter or mean sac diameter 25 millimeter. So here, this time-based criteria should be used. So when the initial scan shows gestational sac without yolk sac and embryo, call the patient after 15 days. When the initial scan shows yolk sac but no embryo, call the patient after 11 days. And initially, if the gestational sac is 12 millimeter with or without yolk sac, call the patient after 7 days. And even if after follow-up scans, you don't get fetal pole with cardiac activity, then you can label this as a failed pregnancy. Now coming to suspicious findings, these are not definite findings. These are gray zone parameters, small sac size, empty amnion sign, embryonic bradycardia, and expanded amnion sign. Gray zone parameters means those values which are below the cutoff 7 millimeter and 25 millimeter mean sac diameter. So here follow-up is needed. Small sac size. Normally, gestation sac is considered larger than embryo. When the difference between mean sac diameter and crown rump length is less than 5 millimeter, we label it as oligoamniotic sac. This is not a definite sign, but you need to give a follow-up for good outcome. Coming to empty amnion sign. So normal order of appearance already mentioned is first the gestation sac, then yolk sac, then embryo, and then amnion. Here, the amnion is seen first, but embryo is not visualized, which is abnormal. It carries poor prognosis. It could be mistaken for two yolk sacs in monoamniotic monochromatic twins, so you should image carefully. Embryonic bradycardia is associated with abnormal outcome. Severe bradycardia is associated with less than 1% survival rate. Coming to expanded amnion sign. Here, embryonic cardiac activity is normally seen before amnion is seen, but in this case, there is visualization of embryo that is surrounded by amnion, but it has no cardiac activity. Coming to yolk sac abnormalities, it can be absent yolk sac, it can be large yolk sac that is more than 7 millimeter, or it can be calcified yolk sac. All these can be associated with abnormal outcome or failed pregnancies, but some cases may show good outcome also. So this is not a definite sign. You need to give follow-up for fetal cardiac activity in future. Irregular shape of gestation sac is also associated with poor outcome, but again follow-up is needed. Subchorionic hematomas, these are very common. They are not significant, but if the hematoma is larger, that is covering more than 2/3 circumference of the sac, and if the pregnancy is less than 8 weeks gestation, then there is increased risk of miscarriage. There is another sign. You can see there are small echogenic lines in extraembryonic coelom. This may suggest hemorrhage, and this is not associated. This is associated with many cases of failed pregnancy. Now coming to ectopic pregnancy, we are not covering each and everything of ectopic pregnancy. We are discussing just imaging part. So 95% of ectopic pregnancies are tubal, out of which majority are seen in ampullary region. So the signs associated with ectopic pregnancy are blob sign, which is seen in 60% of cases, Badgel sign seen in 20% of cases, and the most direct evidence seen in the visualization of gestation sac with or without yolk sac, with or without embryo, with or without cardiac activity in 20% of cases. So this is blob sign. This is the inhomogeneous adnexal mass in the side of ovary, which is seen in 60% of cases. The most important thing to remember here is these two are separate. You should separate these two lesions. So you should separate this lesion and ovary. Next one is Badgel sign. You can see this small gestation sac in the homogeneous adnexal mass. Third is the easiest way to diagnose ultrasonography, because you can see gestation sac with or without yolk sac, with or without fetal pulse, with or without fetal heart rate in the adnexa. It doesn't give you headache, clear-cut diagnosis, and amount of hemiperitoneum tells you rough idea of the hemorrhage into the peritoneal cavity. There are various non-tubal ectopics: interstitial pregnancy, cervical pregnancy, ovarian pregnancy, pregnancy in rudimentary horn, ectopic after hysterectomy. But two things need mention here. One is scar ectopic and another is heterotopic pregnancy. So the ultrasonographic features of scar ectopics are 4 important criteria: empty uterine cavity, empty cervical cavity, gestation sac seen at the cervico-semitic junction, and very thin myometer anterior to the gestation sac. Heterotopic pregnancy is not very common. That is concurrent pregnancy in uterine pregnancy as well as pregnancy outside the uterus. In natural conceptions, the incidence is 1 in 30,000, but in ART clinics, it is much higher, 1 in 500. So if you are a sonologist working in a busy ART center, you have to look very carefully into the adnexa. Then coming to validity for mole. Complete mole, typical snowstorm appearance. The ultrasonographic diagnosis is almost 100%. But partial mole, you get some fetal tissue here and some vesicular changes in that uterus. So ultrasonographic diagnosis is just 25 to 30%. Many of the times this is diagnosed when the POCs are sent for histopathological examination. So coming to last, you should tune your mind to embryonic morphology. You have to just see beyond the cardiac activity and measurement of feti. With advent of newer machines with very, very good resolution, you can diagnose various abnormalities like acrania, holoprosencephaly, ventriculomegaly, body stalk anomalies at around 9 to 10 weeks of gestation. This is a very nice article, sonographic detection of fetal abnormalities before 11 weeks of gestation. Nuchal translucency has been studied before the cutoff of 45, and the nomograms are also available. So, take home message from my side. You should remember the chronology of the and order of appearance of the signs in early pregnancy. Anything wrong in that may lead to failed pregnancy. Transvaginal sonography is the modality of choice in evaluating normal pregnancy, normal early pregnancy. Don't be in haste to label the pregnancy as failed pregnancy. Always give some time. There is no harm in waiting for a few days. And you should think beyond cardiac activity, dating, and number of fetuses. Thank you. Thank you for this. And I need support from all of you for my candidature for Chairperson Imaging Science Committee for election 2024. Thank you.
Thank you. Thank you so much, sir. Such a simple and informative session. I would request Dr. Sridevi ma'am to give expert opinion.
Sir, it was an excellent session, sir. The early definitions, everything you have elaborated very nicely, sir. Thank you very much, sir. Thank you, sir.
Thank you. Moving toward our second session, I would like to introduce our chairperson, Dr. Venkateshwar Rao. Sir, slides, please. Slides, please.
Sahita.
Dr. B. Venkatesh Rao, sir, he is a MD DGO, Professor of HOD Guntur Medical College. His field of interest are high-risk pregnancies. President of Andhra Pradesh OBGY Society, organizing chairperson of state conference. He is presently president of Guntur OBGY Society, conducted CMEs and workshop, presented many paper in the national and state conferences. He has a many publication in the international and national journals. He is an examiner for the UG and PG in various South Indian universities. He's participated in many social health program. He's a past IMA member of Guntur branch. He has conducted many training programs in the national and state level, sports university player in the TT and cricket. Welcome, sir. I would like you to invite our second speaker.
Thank you very much, madam. Slide, please. So thank you very much, sir. Sujit, sir, for inviting me as a chairperson. I wish you all the best in your future endeavors, sir. And your slides are very good.
Kindly show the slides, please.
Yes, ma'am.
I think instead of wasting time,
Yeah,
time?
I like to invite the speaker, Dr. TLN Praveen, and Professor of Radiology, Director Abhishek's Institute of Imageology. He is practicing fetal medicine for past 35 years, and he is very passionate looking at the fetus, teaching training programs, and he has many awards to his credit, Certificate of Excellence, and then the gold medals for Ashok Mukherjee, Lifetime Achievement Award, and he has published a chapter in a textbook of radiology, published peer reviews, and a lot of academic interest. He was a past Vice President National IRIA and a past President IFUMB, President Society of Fetal Medicine. Welcome you, sir.
Thank you. Thank you, Dr. Venkateshwar Garu. Before I start, I would like to thank Sujit, Swati, as well as Paradesi. My association with them is, maybe more than a decade. And I always enjoyed going to Aurangabad and being with them. And they're such a nice people to be with and to share my, whatever the little experience which I have. Shall I share my screen, please, now?
Yes, sir.
Yes, sir.
Okay. Today, I've been asked to talk to you or share my experiences regarding the first trimester structural abnormalities. Sujit has taken us through the normal and abnormal appearances of the first trimester, particularly early pregnancy, in the form of early pregnancy definitions, terms, as well as the abnormalities that we come across, or bad prognosticators, which are suggestive of a poor outcome or early pregnancy failures. Now, as we all know, the first trimester scan is basically called as the first trimester screening for aneuploidies. This was the way back since we have been practicing first trimester ultrasound. This is one of the most important goals that we try to achieve. Now we need to raise the standards. That is, we start identifying the structural abnormalities, particularly because of a wonderful technological innovations and developments that have taken place, and our ability to understand normal anatomy and to identify the abnormal anatomies, as well as improving the skills of our operators who have now been able to identify normal and abnormal structures with much more precision. Now, there is one most important thing that we have to keep in mind is that in the first trimester structural evaluation, there are certain abnormalities wherein 100% of the times you can identify the abnormality. Whereas there are certain abnormalities, about 50% of the times, we may be able to identify them. They are what are called as the fence sitters. So our aim should be to push these 50% ability to identify abnormalities to 100% ability. So that's how we are striving hard to reach that standard so that we can try and identify most of the abnormalities, except the evolving abnormalities. Evolving abnormalities is definitely, you cannot change the embryology. So that is the reason why you have to be very careful about these evolving abnormalities. With this brief introduction, I would like to give you certain key points. One, I would like to introduce this topic, and I would like to put down the approach which we are going to take in evaluating the structures in the first trimester. And definitely we need to follow the guidelines or the protocols in order to identify the structural abnormalities. Then there is one set of abnormalities that we have to keep in mind. That is what is called as the abnormalities that can be detected in the pre-NIPT scan. This is an extremely important component of our evaluation in the first trimester. And what are all the proposed plans in evaluating the structures? What are you going to look for and how are you going to look for is what is important here. Then what are the abnormalities we should not be missed? And what are the approaches that we are going to take in pushing these fence sitters to definitely detectable abnormalities? And I'll give you a few key messages. Now, as Sujit has already told us that first trimester scan, particularly the 11 to 14 week scan, that is when the CRL is between 45 to 85 millimeters of CRL, it is basically labeled as the dating scan. One most important principle that all of us have to realize is that any period of time, gestation, when a patient is sent to you, it is essential that you need to look for the structural abnormalities, not only in the first trimester. Anyway, the second trimester is always known as the anomaly scan. The third trimester is known as the growth scan, but don't stop evaluating the growth only. Please look for the abnormalities. I think Tulika, she's going to take us through that particular part of it. So it's an extremely important message that I wanted to give you is that never stop looking for abnormalities, whether it is in first or second or third trimesters. Now, the other important component which we all used to do is screening for aneuploidies and preterm preeclampsia. Now, in this era where the NIPT has become an established screening method for assessing risk of aneuploidies, it is essential now to identify non-chromosomal structural abnormalities. So when do we do this? This is ideally done where the structures are evaluated between 12 to 13 weeks of gestation, particularly when the crown rump length is around 65 millimeters. Ideally is 12 weeks, 3 days, and size does matter. If the embryo is too small, the evaluation of these structures become very difficult. That is the reason why it is usually done between 12 weeks, 3 days. Now, what are we going to use? We are going to use high frequency transducers, usually 2 to 9 megahertz, that is transabdominally. and transvaginal examination by 5 to 9 megahertz. Remember, most of my cases, which I'm going to show you, are done transabdominally. Very rarely I use a transvaginal examination. Now, with the present generation high-frequency transducers, evaluation of structures or structural abnormalities is almost in 90 to 92% of the cases. We definitely can achieve a diagnosis by using transabdominal. Rarely we may go in for evaluating through transvaginal examination. Now, what is the incidence of this non-chromosomal structural abnormalities? It's about 1.7%. Now, the requirements, what are the most important requirements that we have to keep in mind while evaluating this first-time structural abnormalities? First and foremost thing is high-resolution ultrasound unit with high-frequency transabdominal as well as transvaginal transducers. Remember, there were days when people used to say that the man behind the machine is very important in order to identify abnormalities or whatever while using ultrasound. But now I don't agree with it. I would say that it is the machine in front of the man which is going to play a very, very important role in identifying. Unless you have a good machine with a good resolution, your ability to identify these abnormalities will become very, very difficult. So that is one most important thing. Then next is, over a period of time, as you keep doing it or keep evaluating the first time structures, you develop the expertise as well as the skill to identify the normal structures as well as the abnormalities in the first trimester. And another aspect which I want to insist upon is that we need to follow protocols. There is no shortcut to protocols because protocols are the ones which are laid down with a lot of work that is being put in and a lot of research that has been done, and it definitely helps us to methodically, systematically approach evaluating these structural abnormalities. Now, another important thing is, as Sujit has already told us, appropriate usage of color Doppler is extremely important. Here, when I say color Doppler, it is only color Doppler. I am not meaning to use a spectral waveform. So that is one thing which we have to keep in mind. Short bursts of color Doppler are extremely useful in evaluating the structural abnormalities, particularly when it comes to cardiac abnormalities. So with this background of the requirements, this is the transducers at high frequency transducer. Then we have to develop the expertise. Then we need to have protocols, follow the protocols, and at the same time, we need to use color Doppler. So these are the 4 pillars of evaluating first trimester structural abnormalities. Now, there are guidelines which have been categorized as minimum and advanced guidelines. As I said, the transducers are high frequency transducers. Usually what we try to do is we start off with the fetal head and brain, where quite often, as we all know, that we start off with the axial view or the transverse view of the fetal head, wherein we would try to evaluate the calcification of the cranium, contour, shape of the cranium, and whether there are 2 brain halves and they are separated from each other by the interhemispheric fissure or the falx cerebri. This is very, very important basic thing that you have to do whenever you start off. At the same time, try to identify the echogenic coronoid plexus which fill the whole of the lateral ventricles. This is basically what is required as far as the fetal weight. But then this is a minimum requirement, whereas the advanced requirements I will take you through as I take you through the lecture. Then comes the neck and heart, where you do the sagittal section of the head and neck. Not only that, it confirms the nuchal translucency, and at the same time, as far as the heart is concerned or the thorax is concerned, we take the axial section, which accommodates the 4-chamber view of the heart. Then we have the abdomen, where we try to evaluate 3 most important physiological cystic areas in the fetal abdomen. 1, try to look for the fetal stomach as well as the fetal bladder at the moment you start evaluating the fetus, because once they are empty, there is no way that you can be sure whether they are normal or abnormal. So it's always essential that you need to first look for them and then also look for the gallbladder. But then in the first trimester, you don't really look for the gallbladder, but these 2 structures you have to definitely look for. Now, another important factor is the intact anterior abdominal wall is an extremely important thing because it is associated with various chromosomal abnormalities. They are supposed to be the indirect signs or surrogate signs for aneuploidies. This is basically done by axial and sagittal view, where the bladder is visualized and it is not dilated. Extremities have to be looked for. Placenta, that is ascertained normal appearance without any cystic structures. biometry has to be taken, particularly in the form of crown rump length, nuchal translucency, and in the axial view, you take the bipyramidal diameter. Here, I would like to tell you one most important aspect of it. So quite often when we try to evaluate the first trimester embryo or the fetus, what we do is we try to evaluate the gestational age or date the pregnancy based only on crown rump length. But remember, from now onwards, if you start measuring all the structures, for example, the bipyramidal diameter, HC, abdominal circumference, long bone measurements, there are these measurements, even though they may not be directly contributing to the biometry as well as the assigning the gestation age, but it will help you to look those structures so that you can start identifying the abnormality. So from now onwards, it should be that not just the crown rump length, but bipyramidal diameter, abdominal circumference, and limb measurements are also very, very essential because they help us to pick up very early abnormalities of the fetuses. Now, coming to the advanced guidelines. Now, as I said before, in the head and brain, these are the structures which we were trying to evaluate. But now we have extended the evaluation of fetal brain at 12 weeks is to identify the thalami, identify the brainstem, identify cerebral peduncles, aqueduct of Sylvius, intracranial translucency, and the cisterna magna. See, this is way ahead. That is, you now start evaluating these structures much more precisely. Then comes the face and neck. This is again one leap of identifying the various structural abnormalities of the face and neck, particularly the forehead, both the orbits, lens, as well as the nasal bone, maxilla, a retronasal triangle, upper lip, and mandible. Of course, the nuchal translucency, anyway you are going to do and identify whether there are any jugular sacs or not. I'll take you through each of these structures so that you can understand how to identify them. Then next comes the thorax, wherein we try to evaluate the shape of the thorax, lung fields, the uniformity of the echogenicity of the lungs, as well as any mediastinal shift indicating diaphragmatic lack of diaphragmatic continuity, resulting in congenital diaphragmatic hernias. Heart activity, previously used to see that the 4-chamber views are sufficient, but then now the advanced guidelines say that you need to identify the outflow tracts as well as the 3-vessel view, which gives us much more details. Not only that, the most important thing is assessing the axis of the heart, which is extremely important. Then comes the abdomen. It's almost the same things, whereas the kidneys can now be seen very, very well. One word of caution here is that the first trimester kidneys are usually echogenic. Don't get biased or don't get carried away by the increased echogenicity of these kidneys, which is normal because you are using high frequency transducers. Then comes the regular shape and continuity of the spine is the one which we have to keep in mind. So this is what is advanced guidelines, which can be achieved by all of us. And if you only thing required is that you need to practice them every day, then you will definitely get it. Now, what is the proposed plan in evaluating these structural abnormalities? First and foremost thing, as we all know, we start off dating the pregnancy by taking the crown rump length. Not only that, as I said, now I start looking for the bipyramidal diameter, abdominal circumference also, so that I can start identifying abnormalities of the fetal brain as well as the abdomen. Then I would like to see the card insertion into the placenta as well as the multiplicity of the pregnancy. Remember, one most important thing is once you say there are multiple pregnancies, it is essential that you need to assign the chorionicity and amnionicity, because without chorionicity and amnionicity, your statement of multiple pregnancies doesn't have any value. Now, coming to the fetal head, as I said, the axial view is the basic view that we try to use. And this is the basic transventricular plane where you can see the interhemispheric fissure dividing the two cerebral hemispheres. Not only that, you can see nicely fluid-filled ventricles on either side, which are almost filled by the choroid plexus, and there is only a small amount of fluid in the frontal horns. I am going a little in detail because these are the things that you need to know. So I may take a little more time if the chairman permits me. And then next comes the transthalamic plane where you can see the thalamus, as well as this is a beautiful structure. This aqueduct of Sylvius can never be identified in the second and third trimester, but this is the time when you can really, really well define the aqueduct of Sylvius, and the distance between the aqueduct of Sylvius and the occipital bone is extremely important, particularly when you want to evaluate for Arnold-Chiari type 2 malformations. Then comes the posterior fossa, where you can see the cerebellar hemispheres, the cerebellar hemispheres. Then you have the fourth ventricle, that is the communication with the cisterna magna, that is the Blake's pouch, which you can see very nicely. Now, coming to the sagittal section, here in the sagittal section, you can beautifully demonstrate the thalamus. Then you have the brainstem, you have the intracranial translucency, and then the cisterna magna. So this gives an extremely important, and this section, which we all of us have been following in identifying or dating the pregnancy, and not only dating the pregnancy, to identify the nasal bone as well as the nuchal translucency. This is the section which we have been using, and there is added information that you can obtain by just taking this one particular section, which I will show you as I take you through. Then comes the frontal view, where you can see both the orbits very nicely demonstrated. You can also see the lens beautifully demonstrated. And then this is the retronasal triangle, where we have the nasal bones, we have the palate, and you can see two ossific centers, which are actually the mandibles. So at this stage of pregnancy, you need to identify two ossific centers of the mandible. If you identify only a single ossific center of the mandible, it is usually associated with retrognathia or a micrognathia. So these are all the various things that you can identify by methodically approaching it. Similarly, when you do a four-chamber view, this is the four-chamber view you can easily do. Most important thing which you should realize is, even if you can't get the outflow tracts, at least try to get one good four-chamber view and one three-vessel trachea view. Now, remember, another important factor is, if you don't put the color, it is very, very difficult to identify the atrioventricular flow as well as the three-vessel views documented. So that is the reason why we definitely use color, so that we can identify it. Not only that, as I take you through the lecture, I will tell you the importance of axis of the heart, which is extremely important clue in identifying congenital heart abnormalities. Then comes the fetal stomach, where I could find the cystic area, physiological cyst in the left upper quadrant, which is basically the stomach. Then the insertion of the umbilical cord is extremely useful, because once you have identified the umbilical cord insertion into the anterior abdominal wall, you can rule out supra-umbilical, umbilical, and infra-umbilical anterior abdominal wall defects. Then we have the bladder, another cystic area in the pelvis. In order to confirm that that is the urinary bladder, put the color doppler on. If you see two vessels skirting that cystic area, then it has to be definitely a bladder. And these skirting vessels have to be umbilical arteries. So we have to identify whether there are two vessels which are skirting the bladder, or there is only one vessel which is skirting the vessel, wherein you know that you are dealing with a two-vessel cord or a three-vessel cord. Then comes the bladder, as well as you can see the kidneys so nicely demonstrated, wherein they are slightly echogenic. That is basically, as I said, is because of the high frequency transducers. Now, the spine has to be evaluated, even though the mineralization is not as good as you see in the second trimester, but quite often you can, to a very great extent, identify the vertebral bodies very beautifully till to the sacral region. Then comes the extremities, that is the four extremities, three segments. These are the most important thing that you have to identify. There is the presence of femur, tibia, fibula, humerus, radius, ulna. Not only that, the alignment between the hand and the forearm, alignment between the foot and the leg are extremely important in order to identify talipes and genu recurvatum. And then not only that, this is the time when you really can look at the fingers, because this is the time when most often the fetus keeps its hand open, so that you can, digital abnormalities can be picked up very easily. But once it goes into the second trimester, it becomes very difficult, because quite often it keeps a closed fist. So that is the reason why you need to look for them. Now, as I said, this is a wonderful section. I'm sure all of us have been taking this particular section. Here, this is the crown rump length that has been measured from the crown to the rump region. Now, this is the nasal bone which we look for, and then we have the palate, which we can demonstrate it very well, and then we have the falx. This echogenic curtain-like structure is the falx cerebri, and then we have the thalamus, and then the brain stem, and then the intracranial translucency, and then we have the chin, that is the mandible, and we have the stomach as well as the bladder, as you can see, and the insertion of the umbilical cord. So all these structures with just one section of sagittal section of the fetus, which is quite often used to identify the crown rump length or measure the crown rump length, is extremely informative in identifying most of these structures. So remember to identify all these structures whenever you do a crown rump length. That is the spine. Okay. Now, as far as the screening of aneuploidies is concerned, we definitely look for the nasal bone as well as the nuchal translucency. Not only that, you do the 4-chamber view, identify the right atrioventricular, that is the tricuspid valve, and place your spectral waveform so that you can identify the normal spectral waveform across the tricuspid valve, because whenever there is a regurgitation, you know that you are dealing with a tricuspid regurg, which is one of the features, the ultrasound markers of aneuploidy, and then the ductus venosus, wherein you have the ventricular systole, ventricular diastole, and the atrial contraction. Whenever there is an abnormal atrial A wave, particularly in the form of a reversal of A wave, it indicates that there is a aneuploid. Now, as I've been telling you, these ultrasound markers, that is the nasal bone, increased nuchal translucency, tricuspid regurgitation, abnormal ductus venosus flow are indicative of aneuploidies. Not only that, they are also indicative of a possible cardiac abnormality. So, for example, if you have a fetus where you have identified that there is these nuchal translucency, tricuspid regurgitation, and ductus venosus flow are abnormal, when you get an NIPT, or no, when you get an invasive testing, if it turns out to become a normal karyotyping, in that situation, there should be a strong suspicion that there is a cardiac abnormality. So these are indirect surrogate markers for cardiac abnormalities. So keep this in mind so that I'll take you later. And then, of course, in the first trimester, we definitely look for the uterine artery Doppler, which is very important for preterm preeclampsia. Now, there is this one particular area which I want to spend a little time is cell-free DNA. I know most of us have been using this cell-free DNA, particularly it is usually done at about 10 weeks of gestation, particularly to screen for chromosomal abnormalities, that is to identify the increased risk or no risk for chromosomal abnormalities. Now, as this the NIPT or cell-free DNA is done at about 10 weeks of gestation, there has been coined one more procedure which is called as the pre-NIPT scan, which is usually done between 9 to 10 weeks of gestation. Why is it done? Because it has a potential to change prenatal management of genetic testing. But I'll give you a few examples wherein, suppose if you do a pre-NIPT scan, if you detect a non-viable fetus, do you would like to do an NIPT at all? So there is no need for screening because patient may not be presenting clinically with spotting or a lower abdominal pain or cramping or whatever it is. But when you do a pre-NIPT scan and you find that the embryo is not viable, then definitely it has to be, there is no point in doing an NIPT. Similarly, if you identify a structural abnormality at NIPT, that is, for example, you have identified an lobar holoprosencephaly, that doesn't make any sense doing an NIPT because directly you would like to do recommend a direct diagnostic test pertinent to that abnormality. So that is 2. 3 is whenever there is a multiple pregnancy, that doesn't make, so which is not identified because of the clinical examination. But when you do a pre-NIPT scan and you identify that there are multiple gestation, definitely you need to go for a traditional screening rather than the, such as the double marker rather than NIPT. Then whenever there is a pregnancy which is less than 9 weeks, it doesn't make sense asking the NIPT because NIPT is usually done at about 10 weeks of gestation. So these are all the clinical scenarios which will be potentially identified by doing what is called as the pre-NIPT scan. Not only that, there are various abnormalities that can be picked up in the pre-NIPT scan, such as, for example, this is a classical acrania or anencephaly, wherein you can see that this particular fetus has got a bulging cranial content with echogenic amnion. This is basically because of the amnion acts as a neurotoxic material. So there is a brain digestion that is taking place. That is the reason why you find this sort of a echogenic amniotic fluid. Now, here this is a classical monoventricle, which is highly suggestive of a lobar holoprosencephaly. Then this particular case, where this is almost about 6 weeks of gestation, where you can definitely identify it very easily an ectopia cardis. Then we have the body stalk abnormalities, so very nicely demonstrated, where you can see that there is increased nuchal translucency, high drops, ectopia cardia, and then most of the liver is outside and it is almost attached to the anterior wall, that is the placental region, which with a crooked spine, that is the kyphoscoliosis, which is highly suggestive of a body stalk abnormalities. Now, here we have a conjoined twins where you can see that there is a craniophagus, and this can be identified right at about, I think it was about 9 weeks, 3 days. So these are all the abnormalities that can be easily picked up in this pre-NIPT scan. Now, coming to the first trimester structural abnormalities, this lady Singalaki has done an excellent work, and she has published in 2019 a wonderful paper which is pertinent to more than 1 lakh singletons evaluated between 11 to 14 weeks for structural abnormalities, and these abnormalities have been followed up in the second and third trimesters. And all these abnormalities are taken, or all these patients have been taken only after ruling out the possibility of a chromosomal abnormality. Now, according to her statistics also, she says that almost 98% of them are identified by transabdominally, only 2% required transvaginal examination, and there were almost about 474 abnormalities that have been detected in the first trimester. So this is the impact. Actually, this has revolutionized our evaluation of fetal structural abnormalities. There are certain red flags in the detection of anomalies in the first trimester, particularly when you have something which is projecting out like this. Now, this could be a physiological hernia, or it could be a pathological the omphalocele. So the first and foremost thing, you need to differentiate between the two, which definitely prompts you to think in terms of a possible aneuploidy. Then you can, if you carefully see, you see that there is an increased nuchal translucency, which again is a wonderful hint stating that there can be an aneuploidy or there can be a structural abnormality. For example, you have a trisomy 18 or 13, it can be increased nuchal translucency with the structural abnormality. So that is one. Second thing is there are direct features. Suppose, for example, here you can see that there is a large posterior fossa cyst. Associated with it, there is an increased nuchal translucency. Again, this is an extremely important feature or a red flag which prompts us to go thoroughly evaluating. Sometimes you can have the family history. This lady actually came to me for the second time. This baby was this is the second pregnancy. First pregnancy, when she came, I diagnosed the cephalocele with multiple cystic areas in the kidneys, that is the multicystic dysplastic kidneys, which was absolutely the Meckel-Gruber syndrome. So these are autosomal dominant. So most important thing is when I started looking for the second pregnancy, my mind already has been tuned that the family history is suggestive of a possible Meckel-Gruber. So I have focused on to it so that I can identify the defect in the occipital region with projection of a cephalocele. So this is one thing which will help us. Then if you systematically evaluate the whole structures, then you can definitely identify. There are sometimes when you find this sort of a cystic area at the lower spine, you need to think in terms of either an open or a closed neural tube defects. Now, in 11 to 14 weeks gestational scan, there are anomalies detections they can be categorized as 100% detection rate. These are the abnormalities which have to be detected in the first trimester. That is acrania, exencephaly, anencephaly sequence, yellow bar holoprosencephaly, exomphalus and gastroschisis, megacystis, body stalk anomalies, cystic hygroma, and few cardiac abnormalities. These are positively detected. Whereas these are the ones which we are really, really interested and want to push this into the 100% detection rates, particularly the major cardiac abnormalities, identifying the diaphragmatic hernias, so identifying spina bifida, facial abnormalities, lethal and non-lethal skeletal abnormalities, and renal abnormalities. This is a 0% detection rate, particularly, as I said, evolving abnormalities. For example, corpus callosum, we will definitely not be able to identify the abnormalities of the corpus callosum before 20 weeks of gestation. So that it doesn't make any sense in trying to evaluate these in 11 to 14 weeks of. Similarly, the cerebellar hyperplasia, CPAM, that is sequestrated lung, and then the duodenal atresia, bowel obstructions, because quite often they manifest late second trimester. So these are the things that you have to keep in mind while evaluating. Now, these are the classical ones which should not be missed. That is the acrania, exencephaly, and then the anencephaly sequence. Then we have the yellow bar holoprosencephaly, where in this the prosencephalon, that is the forebrain, fails to develop into two cerebral hemispheres. Usually they are associated with facial abnormalities, and it should be detected in the first trimester because it has a very poor prognosis and needs to be terminated. Now, just to take you through, this is the normal brain. That is the axial section, and this is also an axial section where you can nicely see the interhemispheric fissure separating two cerebral hemispheres. Not only that, this is the interhemispheric fissure with the choroid fixus filling the whole of the lateral ventricles. This is what is called as the typical butterfly appearance, which is when it is distorted, you know that you are dealing with a monoventricle with a uncleaved thalamus. Mark my word, I said uncleaved. I never said fused thalamus. This is the common term which is used as fused thalamus. Please stop using that. It is not correct. This is basically the cleavage abnormality. So this is an uncleaved thalamus and associated facial abnormalities like proboscis. So these are all the things that you have to keep in mind. Then I already shown you the cephalocele. This was the same baby which they were desperate because this is the sagittal section. You can see the herniation of the brain parenchyma, and at the same time there was the herniation into the cervical region, which is classical Arnold-Chiari 2 malformation. Then comes the anterior abdominal wall defects. As I said, we're identifying the insertion of the umbilical cord into the anterior abdominal wall rules out supraumbilical, umbilical, and infraumbilical abnormalities. This is a classical omphalocele where you can see a membrane which is in, and you put the color Doppler on, you can see that the umbilical cord opens into the apex of the defect, so that you know that you are dealing with omphalocele. Whereas here, you can see free-floating bowel loops, and whenever you put the color Doppler, it will be to the right of the umbilical cord, will be to the right of the defect. So these are the two things that can be easily picked up in the first trimester. Of course, associated with it, we have the body wall complex or the body wall anomalies, where you have multiple abnormalities like the spinal dysraphism, as well as the omphalocele, and it is quite often associated with the limb abnormalities also. Now, coming to the megacystis, this is one of the most important things that we have to keep in mind, is identifying the bladder. As I said, it's a physiological cystic area, and the normal is usually less than 7 millimeters. What is the 7 millimeters? It is actually the craniocaudal diameter. You should remember this. It's not the transverse diameter, but it is a craniocaudal diameter. It should be less than 7 millimeters. If it is more than 7 millimeters, we call it as megacystis. Now, this megacystis could be due to various obstructive pathologies like the lower urinary tract obstruction, cloacal persistence, urogenital abnormalities, megacystis, microcolon syndromes, aneuploiditis, and TTTS. Whereas, if the megacystis, that is this diameter of the bladder, is more than 15 millimeters, you know that you are dealing with the lower urinary tract obstruction. Whereas if it is between 7 to 15 millimeters, we need to strongly suspect the possibility of a chromosomal abnormality. So less than 7 is normal. 7 to 15, we need to think in terms of a chromosomal abnormality. More than 15, you need to think in terms of a lower urinary tract obstruction. Then comes the neck abnormalities, where you can see the various abnormalities, like you have a cystic hygroma. Not only that, the same patient, when we did the fetal heart examination, you can very nicely demonstrate. This is basically because your ability to diagnose this hypoplastic left heart syndrome was much more confident because of putting the color on, wherein you can see that the left ventricle is very small. That is the aorta. That is the left ventricle. There is subcutaneous edema. You can see that there is only one atrioventricular valve. This is basically because of hypoplastic left heart syndrome. This was also associated with lobar holoprosencephaly. As I said before, the first trimester's aneuploidy markers are extremely important associated with it. If once we can identify the axis, it enhances our ability to diagnose cardiac abnormalities. For example, to start off evaluating the fetal heart, basically look for 4-chamber view and its alignment with the stomach. We have to identify whether the apex of the heart, which is formed by the left ventricle, is corresponding to the stomach in the abdomen. So when you start the sweep from the upper abdomen into the thorax, what we need to look for is whether the apex of the heart is corresponding to the stomach. As you can see in this particular fetus, the stomach is onto the opposite side, the apex of the heart is onto the opposite side. This is classical situs ambiguous. So that is one thing which you have to be very, very careful, because the situs abnormalities, particularly the situs inverses, becomes very, very difficult, because to identify the laterality of the fetus at this stage of pregnancy is very, very difficult, quite often very confusing. Whereas then next comes the 4-chamber view, both in the grayscale and color Doppler. Remember this, you have to use color Doppler, and whenever you try to evaluate the 3-vessel. So basically, you need to identify the alignment between the apex of the heart and the visceral situs. Then you need to do the 4 chambers. Then you need to do the 3-vessel view. If you follow this protocol, I'm sure most of the abnormalities can be picked up much easier. So here are some of the abnormalities which I would like to show you. Here we have a situs ambiguous, and not only that, you can see a single atrioventricular valve, which is very, very typical of a AVSD. Similarly, here you can see, put the color Doppler on in the same patient, where you can see that there is a single atrioventricular valve, which is responsible for this abnormality. Then we have sometimes we have a hypoplastic right heart, where you can see the walls are echogenic, so it is associated with fibroelastosis. Here, the color Doppler, there is the absolute mitral atresia, and only the flow is across the tricuspid valve. Here, you can see the discrepancy between the ventricular sizes. The left ventricle appears smaller than the right ventricle. Normally, as the pregnancy progresses, there may be a little discrepancy, but at this stage of pregnancy, this discrepancy is not accepted. But then be cautious before you label it as a coarctation of aorta or left ventricular outflow tract abnormality, because sometimes it can evolve over a period of time. So that is the reason why you need to be cautious. Similarly, when you see the 3-vessel trachea view with the outflow tracts, you can nicely see that there is a single outflow tract, and you can see the pulmonary artery is seen very nicely, whereas the aorta, there is a reverse flow. So basically, when you see the 3-vessel view, you are going to evaluate the alignment, number, and the direction of flow. Here you can see one vessel is blue and the other vessel is red. So there is a reversal of flow. So this indicates. Not only that, you can see the aortic arch abnormalities like the U shape, that is the right-sided aortic arch, or you can have or you can have something like a parallel vessels you can see here. So all these things can be identified by just doing a 4-chamber view as well as the 3-vessel trachea view. Now, as I said, we are really interested in pushing the fence sitters, that is a 50% detection rate into 100% detection rate. So these are the things that we have been trying to do. That is the ventriculomegaly, that is the posterior fossa. I'll show you some of the examples so that you can understand very clearly. So this is the evaluation of the fetal waist. Now, first and foremost thing, as I take you, this is the classical axial view of the brain, where you have the interhemispheric fissure, you have the choroid plexus. Next one is the nice evaluation of the frontal face, where you can see the orbits beautifully demonstrated, and you can also see the lens, and you can also see the premaxillary triangle. Then we have the other thing where you have a retronasal triangle as well as 2 ossific centers, which are suggestive of the mandible. Then we have the same 2 orbits. So this is how you have to identify the fetal face. Now, this is the advance that we have achieved in evaluating the fetal face abnormalities right in the first trimester. Now, this sagittal section, as I said, these are all these normal structures that can be seen whenever there is an abnormality, like a decrease in the height of the intracranial translucency, or obliteration of the cisterna magna, or altered BS-BSOB ratio. All these things are highly suggestive of indirect evidence of open neural tube defects. Now, coming to the facial, as I said, it can be very close. The orbits can be close to each other, like hypotellurism, or they can be way away from each other when it is hypertellurism. There can be proboscis, there can be cyclops, that is only a single eyeball, or there can be cleft lips. So these are all the things that can be picked up in the first trimester. Now, this cleft lip, cleft palate, and micrognathia have been published by maxillary gap sign, retronasal triangle, and then the absent mandibular sign. So this is a classical one. When you take the sagittal section, as I showed you, this is the palate you can beautifully demonstrate whenever you are looking for the nasal bone. And now, whenever there is a discontinuity like this, it obviously means that there is a palatine abnormality. So this is right at the 12 weeks of gestation. Now here, we have a normal retronasal triangle where the palate is seen, maxillary bones, nasal bones. Whereas here you can see the maxillary bones on either side, that there is a discontinuity in the palate, which definitely tells us that there is a cleft palate. Then comes the mandible. There are 2 mandible ossific centers, whereas when you find the single mandible, which we did a rendering of this same patient, which shows us very nicely the possibility of a micrognathia or a retrognathia. This is what is called as the faciomandibular angle, also can be used, but this is so obvious. Now, ventriculomegaly, as I said, the whole of the choroid plexus fills the lateral ventricle. So the ratio is more of choroid plexus, less of CSF. Whereas it alters, like more of CSF and less of choroid plexus, it definitely indicates that there is ventriculomegaly. Now, another situation is that the posterior fossa cystic areas, large set of fourth ventricle, more than 19 millimeters, aneuploidy or a posterior fossa cyst. As you can see here, there is a large cyst in the posterior fossa. Now, don't label it as a dandy walker malformation or a Vermeer agenesis, because at this stage of pregnancy, the vermis is not developed properly. So you cannot be sure about saying that it is this thing. Now, spinal abnormalities can be detected by direct signs or indirect signs. I'll just rapidly take you through. These are the direct signs where you find a meningocele, or you can find a discontinuity in the skin, which can be rendered and demonstrated like this, or there can be splaying of the vertebral bodies or widening of the vertebral bodies, which are highly sized off. This thing. Now, coming to the obliteration of cisterna magna and the brainstem. As I said, these are the normal structures. Whenever there is this IT and the cisterna magna are obliterated, then you know that you are dealing with a open neural tube defect where there is a CSF leak. This is what is called as the Akon sign, where the biparietal diameter will be less. That is the reason why I said you please measure the head circumference or biparietal diameter. Similarly, in the transthalamic view, you know that these are the cerebellar peduncles, and these cerebellar peduncles are usually converging posteriorly, and that is the aqueduct of Sylvius. That is the third ventricle. Whenever the cerebellar peduncles become parallel to each other, which are called as the parallel pedicle sign, which indirectly indicates that there is an Arnold-Chiari 2 malformation, that is open neural tube defect. Not only that, sometimes you do find this sort of a poor mineralization. You can see that the vertebral bodies, this is almost about 13 weeks of gestation. The vertebral bodies are very, very poorly mineralized. And at times, you can also find this sort of mediastinal shift where you can see that the heart is pushed to one side. There is a cystic area within the thorax, which is basically because of the diaphragmatic hernia. Now, coming to the renal abnormalities, we have renal abnormalities. Like you see, this is the same lady who had presented to me with multicystic dysplastic kidney. You can see here, that is the cephalocele, and these are the multiple cystic areas in both the kidneys, which are very, very typical of multicystic dysplastic. This is an enlarged or the magnified view, and this is a typical Michael-Gruber syndrome. Now, extremities, as I said, you need to evaluate all the 4 limbs and 3 segments each, and the alignments of hand and foot. Now, here I will show you some of the examples where you can see that there is a loss of alignment between the foot and this. Not only that, here you can see that there is a postaxial polydactyly. You can see there is a cleaving or the clefting of the hand, which is nothing but the ectrodactyly. Here there is fusion of the digits, which is syndactyly, and then here you have a radial ray aplasia. Not only that, the hand is almost directly attached to the upper arm or the arm. And now we have another flexion. This is, you can see that this fetus was persistently in this flexion, fixed flexion deformity of the lower limb. Not only that, you can see there is subcutaneous edema, and also the muscle mass is absolutely less, which is highly suggestive of what do you call it as the arthrogryphosis. Now, then comes the amniotic bands. Also, we have to keep in mind, because they are associated with the limb reduction abnormalities, and you need to assess the umbilical cord as well as the presence or absence of the number of vessels. Now, a word of caution here is that the limitations in detecting anomalies always require reconfirmation at 16 to 18 weeks. This has to be followed, because we are not yet reached the ability to identify all the abnormalities. Most of the abnormalities you can, but it is always better to re-evaluate and reconfirm the abnormality which has been suspected in the first trimester at about 16 to 18. Another word of caution is that always look for the adnexa. This is very, very important, because if you miss a adnexal mass in the form of an ectopic pregnancy, it is of no use identifying, trying to evaluate the structural abnormalities of the fetus. Thank you very, very much for patience listening. And I'm sorry if I have, I think I have exceeded time, but I thought that all these abnormalities I wanted to show you so that it will be useful to you people. Thank you once again.
Thank you, sir. I would request our chairperson, Dr. Venkatesh Rao, sir.
Yeah. It was a fantastic presentation, sir. And you have nicely make us gone through the fetus actually, through all the parts of the fetus, and the videos just like a workshop. Fantastic, this it is just like అట్టుపండు వచ్చి నోట్లో పెట్టినట్టు ఉన్నాయి సార్ యాక్చువల్గా టు టెల్ యూ. It's very good, very nice presentation. And then my one question is, suppose the patient wants to know, you have gone through, you have told us all the soft markers, but what's the minimum period where you can diagnose most of the abnormalities? Because cardiac formation will be, they say that later weeks, 20 weeks like that, complete formation. So what is the best time?
I'll tell you. The ideal time to evaluate the structural abnormalities is 12 weeks, 3 days. That has been accepted now. Okay. Second thing is that not that we can diagnose all the cardiac abnormalities, because whatever the embryological development in the heart is already finished by about 11 to 12 weeks of gestation. Whatever, there are certain evolving abnormalities, like for example, you have coarctation of aorta, or you have a interrupted aorta, or you have a hypoplastic left heart, which converts it into a double outlet right ventricle. All these things, yes, I agree with you that it may not be possible to identify at 12 weeks of gestation, but at least it will give you a clue that there is a complex cardiac abnormality which has to be further evaluated in the second trimester. So that is the reason why I said the caution is that you definitely won't need to ask them to come back at 16 to 18 weeks, so that you are more confident about the whatever the suspicion that you have raised.
So I think it will take to detect most of the. How much time you take, sir?
It definitely takes time, sir. There is no doubt about it. There's no doubt about it, because it all depends upon the baby's position. It all depends upon the maternal habitus. It depends upon the cooperation of the mother, the equipment which you have. So it takes time, because see, there are some situations where I had to do a 3D, and then when I do it particularly for a micrognathia and all, it takes time. It's not that seeing these images are nice, but you should remember that I have picked up the best images and left off the.
Of course. But as you told, the instrument in front of the person is more important. But you have proved that in front of the machine also, people like you can detect most of the abnormalities. Congratulations, sir. Thank you very much for the very nice presentation.
Thank you, sir. It was really indeed a detailed webinar. I would like to invite our third chairperson for third session, Dr. Aruna Kumari ma'am. She has graduated from Rangaraya Medical College, Kakinada, University of First in the final MBBS, post-graduation in Chandigarh, ex-associate professor in GSL Medical College, Rajahmundry, then senior OBGY consultant in Rajahmundry, and areas of interest are infertility and high-risk pregnancy. Started Rajahmundry OBGY Society, conducted many CMEs and Andhra Pradesh state conferences, invited as a faculties in many state and national conferences. Welcome, ma'am. I would like you to invite our third speaker.
Thank you, Swati. Thank you for your kind introduction. First, let me thank Dr. Sujit sir for involving me in this webinar, and all the best, Sujit sir, for your upcoming elections. Coming to introduction of Dr. Tulika Joshi. She got postdoctoral fellowship in fetal medicine. She's a director and consultant of fetal medicine, Tulip Fetal Care, Ranchi.
I think we should skip the introduction for the academic session.
Okay, madam.
Thank you, ma'am.
Start your presentation, ma'am.
A very good evening to everyone. I am Dr. Tulika Joshi. I am from Ranchi. I have already told every one of you. First of all, I would like to thank Dr. Sujit sir for including me in this webinar. Thank you so much, sir. And I congratulate you and best wishes for you all your future endeavors. So today we are going to talk about the third trimester, the fetal assessment in the third trimester. And as Britney Spears say, hit me baby one more time, the we fetal medicine specialists say, check the baby one more time, especially in the third trimester. As we talk about the third trimester, there are many confusions regarding the third trimester scans, that whether what should be the part of the third trimester scan, when it should be done, what should be included in the third trimester scan, whether Dopplers included or not, when it what are the indications, what should be the equipment, and so forth and so on. And what about patient presenting first time in the third trimester? How should we assign the dates to them, which are having small babies or larger babies, and how should we assign the dates to them? And what about abnormalities of growth and the Leica Doppler placenta and third trimester abnormalities? There are many questions in front of us, and thankfully ISIOC with Dr. Asma Khalil has given out ISIOC practice guidelines for the performance of the third trimester obstetric ultrasound scans. And in this talk, these guidelines will be the basis of my talks, and I will go through all those recommendations within the guidelines one by one. So as an obstetrician and as a fetal imager, fetal sonographer, many of you have faced this question, that how many scans, routine pregnancy scans? Earlier there was a fewer scans done in the earlier gestation, and the majority of the scans were concentrated in the later gestation. Then there was a scheme of inverted pyramid and so forth and so on. But we all agree on these three scans, that one scan in the early pregnancy, one anti-NB scan, and one anomaly scan at 18 to 22 weeks of gestation. But what about a growth scan at 28 to 30 weeks of gestation to rule out early fetal growth restriction, and the growth scan after 34 weeks of gestation to rule out the late fetal growth restrictions? These two scans look very good in the well-resourced settings where the institution and the patient both can afford these two scans. But are these actually necessary or not, and why should we do them? So basically, the third trimester scan is usually done for the following indication. Most of the time, especially in this region of the Jharkhand region, it is a first scan of the pregnancy. Patient is coming in the 26 or 27 or 30 weeks of gestation for coming the first time assessment. So the obstetrician send her to us. So we have to assess the gestational age, number of fetuses, whether the baby is large for age or small for gestational age. And sometimes there is a already assessed pregnancy going on. It could be normal, it could be abnormal, but it faces a newer pregnancy complications, which could be antepartum hemorrhage, reduced fetal movements, rupture of membrane. Sometimes it is an adjunct to the procedures such as external cephalic version, and sometimes it is an institutional policy such as ours. But are these scans really necessary? So the guidelines say there is no convincing evidence that a routine universal third trimester ultrasound examination in a low-risk population improves either a perinatal or a maternal outcome. So what comprises of a fetal growth scan? Is it only a biometry scan? Because most of the time you get a report which is only giving the fetal head circumference, femur length, and the abdominal circumference, not even the biparietal diameters. The Dopplers are out of question, and the fetal anomalies don't even talk about the fetal anatomical scans. But in actual, the fetal growth scans comprises of the Doppler biometry with the Doppler assessment, with the fetal environment, which is placenta, liquor, presentation, cervix, the fetal activities, the fetal attitude, all these things, and the fetal anatomical survey. Coming to the fetal biometry, we all know that how to take the biometry. The biparietal diameter is measured in the transthalamic and the transventricular view. These are the landmarks where the calipers should be kept and what should be visible. So I will skip through them. The femur length, we should all know that the femur should be perpendicular to the angle of insertion. It should be completely horizontal. and the beams should fall perpendicular on the femur length. Both endpoints should be clearly visible, such as this. In the abdominal circumference, whenever you are measuring, 2 complete ribs on the either side should be seen, and the kidneys should not be seen, and only a short segment of the umbilical veins should be seen. So we have taken the biometry, but what about the dating? Not this kind of dating. I am talking about the pregnancy dating. The parameters which are used for the pregnancy dating: LMP, last menstrual period, if the patient is having good dates; date of conception, if it is an IVF pregnancy and the date of conception is very good. We know the blastocyst transfer or the embryo transfer date, or by the USG parameters, which could be CRL, biparietal diameter, head circumference, abdominal circumference, femur length, and sometimes the transcerebellar diameters. So we all know that whenever we see if the patient has 11 to 14 weeks scan, we usually compare the gestational age with the CRL. If the discrepancy is of more than 7 days, we reassign the estimated date of the delivery. And this is the golden rule, that once we assign the date in the first trimester, or we assign the dates from the first trimester, we do not change the dates in the subsequent scans. So estimation of gestational age is done. It's not done by the earlier scans, less than 10 weeks of gestation. It is done by the 10 to 11 weeks of gestation, when the CRL is between 30 to 84 mm. But if patient is not having those scans, we can use the 14 to 24 weeks scan, where the gestational age, head circumference, and the femur length should agree with each other. But as per the ISTIO guidelines, after 24 weeks, the size is assessed, but not gestational age. So what do we do for the patients who are presenting first time in the 3rd trimester? For those patients, head circumference plus femur length, or head circumference alone, if the femur length is not available, these are the standard measurements, standard things for the assignment of the gestational age. They rank highest in the recent systematic review by Self et al. And sometimes the transcerebellar diameter can be used because it is less affected by the growth disorders. But all these things have certain limitations, because even though HC plus FL estimation of gestational age it ranks highest, but it has more than 15 days of the variability. And when the pregnancy is in the late 3rd trimester, the head is deep into the pelvic cavity, and it is difficult to assess the fetal head circumference because the endpoints are not clearly visible. And transcerebellar diameter also gives a low prediction rate of around 95%. So what do we do in such cases? We do a biometry, we assess the gestational age, and we call again the patient after 15 days, and we see the interval growth of the fetus if it is following the growth graph such as this. And sometimes we can catch the growth abnormalities, such as large for gestational age fetus, which is defined as the estimated fetal weight above 90th centile, or that at term the fetal weight above 4 kg or 4.5 kg. But the screening for large for gestational age is more accurate in the late 3rd trimester. I'm coming to that point in the later slides. Why is it more accurate? But prenatal identification of microsomia, whether it improves the perinatal outcome, it is questionable, because we do not do the only concern with the macrosomia is the shoulder dystocia and the fracture of clavicles during the labor period. But inducing such patients or doing elective cesarean section in such patients, the guidelines are not so much clear. So the recommendations are screening for large for gestational age in the general population may be more accurate when the examination is performed at 36 rather than the 32 weeks. And health professionals should balance the benefit of induction of labor for the perceived macrosomia with the respect of shoulder dystocia and fractures against the potential adverse effect of the early term delivery. In the small gestational age or the fetal growth restriction, the criteria used are the Delphi criteria. The parameters used are the estimated fetal weight, abdominal circumference, uterine, umbilical, Dopplers, cerebroplacental ratios, and the serial growth measurements. With these methods, with these criteria, we identify those fetuses which are greater risk of the perinatal complications, right, intrauterine fetal death or problems of the growth restrictions. So these pregnancies can be started early in the third trimester for monitoring by the growth and with the help of the Dopplers. And also in this, I would like to reiterate that a scan at around 36 weeks is more effective in detecting the fetal growth restriction than is a scan closer to 32 weeks. So the recommendations are screening for SG and FGR in the general population is more accurate at 36 weeks, and estimated fetal weight and abdominal circumference can be used to screen those SG and FGR with similar performance. So what should be the timing of the third trimester ultrasound scan? It depends basically on the purpose. If the patient has, you have seen the patient first time in the third trimester, and you also want to assess the anatomy of the baby, whether it is normal or not, 32 to 34 weeks of gestation is a very good time period for that, because you are still having a good amount of liquor, the fetus is mobile, and there is a good acoustic window, and so there is less obscuration of the anatomy at this gestation. But the growth abnormalities are best detected at 36 weeks. Why? Because of these two studies by Siobanu A et al. And the Khan and et al. So for the small for gestational age, using estimated fetal weight, the area under the curve at 35 to 37 weeks of gestation was 0.933, more than which was at 31 to 34 weeks of gestation. And same is for the large for gestational age babies, which is the area under the curve for detection was 0.861 for 35 to 37 weeks of gestation, and it was only 0.815 at 31 to 34 weeks of gestation. So the recommendation is the timing of the third trimester scan, if indicated between 32 to 36 weeks, should be decided based on the individual maternal and fetal characteristic, the risk level of the pregnancy, and the local objectives and the resources of the institute. The Dopplers, the routinely used Dopplers are, first of all, they are the mandatory part of each and every scan starting from the first trimester, the level 1 scan, which is 11 to 14 weeks scan. Before that, the Dopplers usually should not be used. But after that, every scan must include the Doppler interrogation of the fetus, the umbilical artery, the middle cerebral artery, and if the fetus in the third trimester is showing some abnormalities in these two vessels, there is altered CPR. So the uterine arteries and the ductus venosus should be interrogated to get a proper waveform. Coming to the fetal environment, it is a placenta, amniotic fluid, presentation, and the cervical. The amniotic fluid is assessed according to issue of practice guidelines for the second trimester scan. We can measure AFI and the deepest vertical pocket, and these two terms are usually interchangeable, but not in the cases of the pathologically raised or decreased amniotic fluid. In the cases of oligohydramnios, which is AFI less than 5 centimeter or deepest vertical pocket less than 2 centimeter, the causes could be fetal abnormalities of fetal renal urinary bladder, the fetal growth restriction, the rupture of membrane, or it could be idiopathic. So if an oligohydramnios is detected, and it is the DVP is more preferably used for the detection of the oligohydramnios. If it is detected, then a targeted examination for the fetal KUB examination and the fetal growth and Dopplers should be taken. A targeted history should be taken from a patient for the any history of leaking or discharge per vagina. And in the cases of polyhydramnios, which is defined as a AFI more than 25 or DVP of more than 8 centimeter, it is mostly idiopathic, but in majority of section also has a maternal diabetes, and rest of the section consists of fetal abnormalities, fetal infection, placental tumors, fetal hyperdynamic fetal condition, which ends up into fetal hyperdynamic circulations, and certain chromosomal and genetic abnormalities. So whenever AFI is diagnosed, and the diagnosis is for the AFI is more preferred for the diagnosis of the polyhydramnios, and when it is diagnosed, a targeted fetal inspection should be taken place to detect any kind of fetal pathology. And the idiopathic should only be labeled after all the relevant causes has been excluded. So the recent issue of guidelines for the third trimester has reiterated those for the second trimester guidelines, that DVP is preferred for over AFI for diagnosing isolated oligohydramnios, as it is associated with fewer induction of labor while having similar perinatal outcome, and for the detection of polyhydramnios should lead to a targeted investigation for underlying cause, as idiopathic polyhydramnios is a diagnosis of an exclusion. Coming to the placenta, every scan should include a placental assessment, and the effect should be made. Even one can use the transvaginal scan to assess the poorly localized placentas or posteriorly localized placenta to diagnose the relationship of placenta to the internal cervical os, especially the leading edge. If the edge is above 20 millimeter, one can safely allow the woman to deliver. The women are also allowed to deliver if it is between 20 mm to 10 mm, but the rate of successful vaginal delivery varies from around 55% to 80%. So the recommendations are assessment of placental location should be a component of the third trimester ultrasound. Women diagnosed with a low-lying placenta or a placenta previa at routine second trimester scan should have a follow-up assessment for the placental location in the third trimester. Women with major placenta previa or a uterine scar may be offered a scan at around 28 weeks of gestation, while women with minor placenta previa may be assessed later in the third trimester. The TVS approach is preferred in cases of suspected posterior placenta previa. Coming to the placenta accreta spectrum or a morbidly adherent placenta, the risk factor are prior cesarean birth, previous multiple suction curettage, or a previous uterine surgeries. The prenatal diagnosis of placenta accreta spectrum is associated with reduced hemorrhagic morbidity in a mother. The third trimester USG has efficacy of detecting as high as 90% of placenta accreta spectrum, but be aware of those 10% because they are all usually diagnosed at the time of the cesarean section, and the patient land up into the hemorrhagic morbidity. So every woman with a placenta previa and a prior cesarean birth or a uterine surgery is always considered as a potential case of placenta accreta spectrum and should be referred to a tertiary care center where these conditions can be beautifully managed. And MRI is advised if there is a difficult to reach placenta, such as posterior placenta previa, previous uterine surgery, or placenta implanted over a myomectomy scar, or if there is a strong suspicion of the parametrial involvement. So what are the USG features of the placenta accreta spectrum? So these are there is a loss of retroplacental clear zone, there is a myometrial thinning, the bladder wall appears sometimes interrupted, there is a placental bulge or an exopitic mass can be seen, there is utrovesical hypervascularity, placental lacunae, and sometimes the bridging vessels can also be seen. And sometimes these features, not all are present, sometimes they are partially present and they are present at some focal location. So exact efficacy of these markers in predicting the placenta accreta spectrum is usually not studied well. So the recommendations are these as follows. I have already said the women with placenta previa and posterior prior cesarean birth should undergo detailed ultrasound assessment to rule out morbidly adherent placenta. Second and third, I have already explained. The MRI can be considered in the cases of an inconclusive ultrasound diagnosis or in cases of severe morbidly adherent placenta, especially if when a parametrial invasion is suspected, and the longitudinal assessment of fetal growth is not required in women with placenta previa or PAS unless other risk factors coexist. For the Vasa previa, the resolution rate is 23%. The risk factors are placenta previa, second trimester low-lying placenta, biloplacenta, placenta with succenturial probe, and the multiple gestation. If it is detected in the second trimester, in effort, especially with the transvaginal probe, should be made for a targeted examination to rule out the Vasa previa. And in the presence of risk factor, it should be an effort should be made again in the third trimester. Coming to my the most emphasized topic, the fetal anomalies. At least 99% scans which we are getting, scan reports which we are getting in the third trimester, they are devoid of any comment on the fetal anatomies. But as Praveen sir has also said that every obstetric scan is an anatomy scan. Whether you are imaging an early embryo or you are imaging a 39 weeks fetus, an effort should be made to assess an anatomy of the fetus, and comment should be given in the report that an effort is made, and these all structures have been seen, because not all structures can be seen in the third trimester scan. But that is also true that not all fetal abnormalities can be detected in the mid trimester. It could be maternal hepitis, some could be developing abnormalities, it could be fetal position, or some abnormalities can easily be missed in the second trimester. So there are certain late presenting anomalies such as genitourinary tract abnormalities, CNS abnormalities such as gyrational abnormalities of the brain, in the heart, coarctation of aorta, the bowel atresia, which shows later, skeletal abnormalities such as hemivertebra, they all are readily seen in the third trimester. So what are the benefits of a scan commenting on anatomy in the third trimester? We can offer these patients for an in utero transfer. Suppose you are in the peripheral location and the baby is having some heart condition which may require immediate intervention. You can offer the patient in utero transfer to a better center. We can do a parental counseling, and the parents will be much readily acceptable for these kind of abnormalities. We can offer them the genetic assessment, prenatal genetic assessment for these fetuses, and if the genetic assessment has already been done, it could be expanded on the basis of the new findings. The postnatal care and the follow-up of the neonate can be arranged, and in certain situations when the law permits, the late termination can be offered to these patients. So what systems should be included? The head, the brain, the heart, the fetal chest should be assessed, the abdomen, and the genitourinary abnormalities should be commented. In the head, the shape and size of the head should be commented. Sometimes the head is breech, it appears more elongated in the breech position, but overall size should be assessed, and it should not be less than 3 standard deviation. And most of the anatomy, I can say that can be assessed in the 3 basic axial planes, the transventricular, transthalamic, and the transcerebellar plane. And an effort should be made out to look at the brain parenchyma and the gyrational pattern of the fetal brain, because the late abnormalities of fetal brain are usually the gyrational abnormalities. If the head is deep into the maternal cavity, the TVS may be a preferred approach. If we have, as we see in the later gestation. In the fetal heart, the situs should be assessed as assessing the situs is same in the early pregnancy, in the mid trimester, in the third trimester. The size, the heart should occupy 1/3 of the fetal thorax. The symmetry of all 4 chambers, the outflow tract, great vessels and their relationship, and the branch pulmonary artery should always be documented. In the third trimester, we are usually not so lucky to get an apical heart because of left occipital anterior position being the most common. We usually get a basal or the lateral 4-chamber view. What I do, I take a sweep of heart showing the 4-chamber, then LVOT, and then the great vessel, crossing of the great vessel relationship. And sometimes, if we are lucky, the branch pulmonary artery can also be seen. The diaphragm in thorax, the diaphragm should be assessed in the coronal and sagittal view. A comment should be made on the lung parenchyma to look for the lesions such as CPAM, and again the situs should be assessed. The abdomen and the urinary system should be looked very carefully, because these abnormalities tend to develop later in the gestation, such as fluid collections, calcification, cystic structures, and the bowel dilatation. One should keep in mind that before labeling the urinary tract dilatation, the cutoff changes from 27 weeks from 4 millimeter to the 7 millimeters. For example, this is the case. This patient was having only one scan that done at 16 weeks of gestation, and that scan only included the biometry. At 29 weeks, 4 days of gestation, there was a cystic mass just behind the bladder of the baby. The bladder was distended, as were the renal pelvises. Both kidneys were echogenic. The abdomen was showing The abdomen was showing cystic echogenic areas with calcified deposits, multiple calcified deposits, and dilated bowel loops. The face, although the face is not given in the guidelines, but my teacher has always told me that even in the later gestation, always and always try to make the nose mouth view. You cannot assess the full fetus, but always and always try to make a nose mouth view so that the cleft of facial cleft can be seen, because this is the defect. Whenever the patient sees the baby, parent sees the baby, they see the face first. So a person should not miss the clefts of the face. So this, for example, this is a case where a patient was in active labor. The gynecologist has sent to me that just see the what for the biometry. Out of habit, I just saw the face view with the nose mouth view, and this is the famous sign of nose falling down in the lips, and there is a discontinuity of the upper lip. I counseled them, and immediately after that, the baby rotated, and I was not able to take any more further views. And this was the view of baby after the birth. Thankfully, I have counseled the patient regarding the abnormalities, and they were very much prepared for the defect. So recommendations are, depending on the objectives of the third trimester scan, anatomical evaluation may be undertaken. And if this is done, should target examination of the head, brain, heart, chest, abdomen, and the urinary system is taken. For my take-home message, I will reiterate that slide that growth scan is not just a biometry, it is Doppler environment and anatomy of the fetus, and no one should accept the half reports which only gives biometry or biometry with the Dopplers. Thank you, and I'm ready for the questions.
Thank you, Madam Tulika Joshi, for your excellent narration of this third trimester scan. It's really a complete revision of a third trimester scan. Thank you so much, ma'am.
Thank you, ma'am.
Only one question. What is your recommendation for a low risk obstetric patient? Which time for the third trimester scan? Is it 28 to 30 weeks, 30 to 34 weeks, or around 36 weeks? Which time you will prefer? You will recommend?
Ma'am, we have to individualize. Now the guidelines are saying in a low risk population, there is no use of a third trimester scan, but at 34 weeks. If the patient is healthy, you are monitoring constantly her with the symphysiofundal height, because in a low risk population, symphysiofundal height is sufficient for any kind of growth abnormalities. Yeah, so if you are suspecting anything abnormal in your symphysiofundal height, then you can send the patient anytime. But if the patient is doing okay in the obstetric visits, then and if you feel that just before delivery, I should have an assessment of the baby at 34 weeks, that is a very well-balanced approach.
I don't know why nowadays the oligohydramnios is more commonly seen. It's a mild to moderate oligo.
Yeah, changes in the mother's dietary habit, sedentary habit, mobility, they are more prone for subclinical sort of hypertension or gestational diabetes. We can say that diet, all these things lead to that.
So to diagnose that mild to moderate oligo, at what time should we do that scan for this low risk patient? Is it 30?
Ma'am, hello.
I think she lost the con.
I think we have lost connection with her.
I will answer her question. If the symphysiofundal height is okay, if she if you are one gynecologist is suspecting the low symphysiofundal height, then immediately there we should scan the fetus, no matter what the gestational age. And just if the symphysiofundal height is going good, then at 34 weeks, it should be, and if the gynecologist want, they should take up. But the guidelines don't recommend routine third trimester screening in the low risk populations.
Can I add one small thing?
Yes, sir.
See, basically most of these guidelines, of course, we do follow the guidelines, but they are influenced by the insurance. In Western world, they have a limited number of scans which are covered by the insurance. So that is the reason why they are very hesitant about getting a third trimester scan. As you said, 34-week scan is an extremely ideal one, because I would prefer to do a 34-week scan, not only for the growth, but also for the relook for anomalies. and at the same time assess the biophysical profile. So these are very, very important factors which we have to. But then in Western world, they are influenced by the insurance policies. So that is the reason why they restrict themselves. But I think in our setup, we definitely, even whether it is low risk or high risk, I would definitely like to get a 34-week scan.
That is the difference, sir. Your experience talks, and what I am doing, I'm just following the guidelines. But that matters, because you told me that it is guided by the insurance, some things, and so that is something, somebody is benefiting from these guidelines, and we should not copy them blindly in the Indian scenarios.
Exactly. That's exactly.
Any more questions? I think we should wrap up our session, today's session. I would like to thank Dr. Sunita Tandurkar Madam, Dr. Venkat Raman Sir, Dr. Radha Lakshmi Ma'am, Dr. Rajendra Singh Pardesi Sir, Dr. Sridevi Ma'am, Dr. Venkatesh Rao Sir, Dr. Aruna Kamari Madam, and lastly to our main speakers, excellent speakers, Dr. Sujit Konkar Sir, Dr. Tulika Joshi Ma'am, Dr. TLN Praveen Sir, for their wonderful presentation. Thank you so much, sir. Thank you so much, Shield Healthcare, for their educational support, and to all the participants who has taken out their time to attend this webinar. Thank you so much.
Thank you, sir.
Thank you, Sujit sir, for organizing such a wonderful webinar. Thank you, sir.
Congratulations.
Sir.
Thank you.
Bye.
We have finished in time. It is 7 p.m. exactly.
Good. Right. See you then. Bye.